Dr. Vescio. Many of you know him. He works at Cedars-Sinai. He heads up the myeloma program there at Cedars-Sinai. He really doesn't need much of an introduction. He's been talking to our group for a number of years. He's always a very engaging speaker when willing to take the time from his busy schedule to answer any question that you might have and to give a presentation on what he feels is the latest going on in myeloma research and news. So what we're going to do is he'll give a presentation, or however he wants to do it, the Q&A, after which we'll take a break, have lunch, and then we can resume with more Q&A that you might have. So without further ado, Dr. Vescio.
Well, it's nice to see everyone, a lot of familiar faces. So I'm going to give a little bit of an overview of multiple myeloma because not every, some people know this, know as much as most doctors, and others are kind of new to the disease. And so I'll start off with kind of an overview of multiple myeloma and talk about some of the newer drugs, how they work. And then really I think the question and answers is often the best thing because usually in my experience the questions you have other people in the audience have, and I'll do my best to try to answer them and make things understandable. Multiple myeloma, there's some controversy. Even the paper you have in front of you, I would say, is controversial. So there's a lot of different ways of treating the disease, and people really haven't figured out everything there is to know about this disease, which makes it kind of exciting for researchers, but the faster things get figured out, the faster we can get people cured and have their disease stay away. It is a disease that's becoming more common. So, a lot of cancers actually are less common. People don't get stomach cancer as often as they used to. But this particular one is increasing, and nobody's really sure why that is. You kind of look at everybody in the room, and when I notice people coming to see me in clinic, there doesn't seem to be much of a common thread as to why people develop this disease. It comes obviously from a plasma cell, so that's what's cancerous in multiple myeloma. So things that stimulate the cancer cells to divide tend to make the disease more likely to happen. So people with chronic allergies, immune system problems are a little more likely to develop multiple myeloma because their immune system's revved up and the cells are dividing, trying to fight off allergies, and then people are a little more likely to develop it. So chronic inflammation, people with rheumatological conditions, and then certain toxins. I mean, if you have things in the environment that can injure cells, then it just makes it more possible for one of the injuries to make the cell a cancer cell and not just kill the cell. And it gets more common as people get older. I think there's just more opportunity, unfortunately, as you get older for one cell to develop mistakes in them. And so that's maybe why it happens more commonly as people get older. And then for some reason it's twice as common in African Americans compared to Caucasians and Asians. And it's not clear why that is, but that seems to be the case for both for men and for women. So again, just showing you how it increases as people get older. This is the number of people that develop multiple myeloma per 100,000 every year. So if you take 100,000 people in a city, than of people that are, if you had 100,000 40-year-olds, 1.5 of those people would develop multiple myeloma. But if you have 100,000 80-year-olds, 40 of them would develop multiple myeloma every year. So your odds go up as you get older for developing multiple myeloma. And these are what the cells look like. They look like fried eggs. This is under a microscope from a sample of the bone marrow, so I'm sure everybody that has multiple myeloma has had a bone marrow biopsy. And the needle goes in and you suck out some fluid, and in there are all these cells that should be, in a normal healthy bone marrow, should be producing blood. The white blood cells to fight infection, the red blood cells to carry oxygen. There's a cell called a megakaryocyte. They make platelets. And then you should have plasma cells in there. But only a few of the cells should be a plasma cell if you don't have multiple myeloma. Only at 1 or 2, 3% of the cells within the bone marrow should be plasma cells. So here, on this person's bone marrow aspirate, basically all the cells with a nucleus. These little red things, those are the red blood cells. Red blood cells are like bags carrying a protein called hemoglobin to bring oxygen through your body. They actually aren't alive. They have no way of reproducing. They kind of mature, and then they just float around as bags carrying oxygen. So all the things that are alive that have a nucleus, which is in purple, you can see on the screen, are these plasma cells. And that's what multiplies. In fact, that one probably in the middle, way over on the right side, that's one that's about ready to split into 2. So that's the way cells divide. One, it's like bacteria. One cell becomes 2. And so it's dividing, and that just keeps happening, and they just keep building up. But the thing that maybe some of you that have been in remission, the doctor couldn't tell you by looking under the microscope. I couldn't tell you that that's a cancer cell. That I can tell you is a plasma cell, but I don't know it's a cancer cell. The way I know this person has cancer is because there's just too many of them. You can't have that many of them and not have the cancer. But when people go into remission, a lot of times the bone marrow will say, oh, we can't even find the multiple myeloma. Well, they may see one of those cells, but what the reality is, they can't tell if it's cancerous or not. So the amount of them are normal in number, so they can't tell if there's any cancer cells left. But unfortunately, most people, when they go in remission, there's probably still some cancer cells in there that eventually will grow back. So again, this is, if you look at how bone marrow cells grow, when we do a stem cell transplant, we take these cells, they're called blood stem cells, and their job is to make all the blood cells. And as they divide, as one cell turns into 2, the daughter cell matures and turns into, like it's been told to go down this pathway and turn into a red blood cell. Then the stem cell divides again, and this one is kind of told to turn into a neutrophil, which you need to fight bacteria. And then another one divides, and that one says, oh, turn into a platelet-making cell. So the stem cells are the reproducing part of the bone marrow. They actually don't help you in any way. They don't fix anything. Their job is just to make the cells that do things. So when people have, so we collect those cells as part of a transplant and put them back in, and then they can grow all the healthy cells down the line. So what happens in multiple myeloma is the cells are maturing normally, and then one of those plasma cells gets a mistake in the DNA, and that's what turns into then forevermore that cell is mistaken, and it divides when it's not supposed to, and it's the cancer cell. So it's probably hard, probably impossible to see. But just without even showing you the idea behind it, depending on during that process, where the cell becomes cancerous determines what type of cancer people have. So when little kids have leukemia, the cancer cell happens right over here. So the stem cells or these early cells is what turns into a cancer cell, and so those cells build up quickly in their bone marrow, and they can't use it. They can't have a transplant from their own cells because their stem cells have the cancer. So you have the little kids, when they get leukemia, they have to find a donor, brother or sister or some unknown person, for them to do a transplant. When the cells, as they mature, they go to the lymph nodes. We all have, lymph nodes throughout our body. If I get a cold, sometimes my lymph nodes will swell up. That's because the body's designed to have that virus kind of end up down there in my lymph node. And then these lymphocytes try to figure out how to fight it off. And they figure out which cells are going to fight it off. And if one of those cells in there becomes cancerous, that's called lymphoma. And then what happens normally is those cells leave the lymph node and go to the bone marrow. And then if it's in the bone marrow, it turns into a cancer cell. That's multiple myeloma. Some patients with multiple myeloma really don't have much in the way of symptoms. Especially, I have quite a few younger patients where they went in for a blood test, sometimes for for life insurance policies or something like that, and they found out their protein was high, and so they said, well, you're not going to get life insurance. We're not going to give you life insurance because your blood's not perfect. And then they figure out why their protein's high, and sure enough, they get diagnosed with multiple myeloma, but they feel fine. They don't have any symptoms. Most people that have the actual cancer do have symptoms. You can get pain from the myeloma as it invades the bones. It can weaken the bones and cause fractures. People get infections because the proteins, the antibody proteins that you need to protect you from infection, often aren't being produced because the healthy plasma cells are not there. There aren't as many of them there in number. And then people can have kidney problems. So a person I just admitted to the hospital yesterday, his multiple myeloma, I guess, wasn't being well taken care of, and it was growing back. And so in order to keep his kidneys from shutting down, he needs some treatment to get the myeloma in better shape, get rid of it. When the myeloma cells grow, if they grow in clusters, they can form these spots. They look kind of like holes in the bones, and that's because the myeloma cells kind of chew away on the bone. They actually stimulate other cells around there to chew away on the bone. So that's what's important. First thing is to get rid of those cells, because if they're not there, they can't be chewing on the bone. And then to take the drugs that can protect the bones, like Iridia and Zometa, the typical ones, that can make it harder for the myeloma cells even there to injure the bone. This particular person, that looks pretty scary to have that spot in the skull like that. This person can be in remission when they had that picture taken, which seems strange because you go, well, that's not normal. How could they be in remission? Because I can tell you they had myeloma, but I don't know if the cells are still there. This is like there's damage done, and the analogy I would kind of use is, I've had termites before in my house, and if you looked in the wall, you could see the termites, and actually you could hear them. And then had to call the guy out, and they killed the termites. Well, a month later, if I was to look inside the wall, you wouldn't see the termites, but you'd still see the holes where the termites were. So if somebody 20 years from now looked into the wall of my house, they could say, you have termites, or you had termites. It's the same with myeloma. This person had myeloma. I don't know if it's active or not. So sometimes people get x-rays and they get kind of nervous because the radiologist will say, oh, there's a lesion there, a lytic lesion. That's what the fancy way of what they call these things. And they're afraid that their disease is back. No, it just means at some point the myeloma caused harm. You shouldn't be getting new ones, but it's at some point they were there. So how do we make a diagnosis? We take the sample out from the bone marrow usually. Sometimes people present with, say, pain in the rib, and they do a biopsy of the rib and they show it that way. But usually you take a biopsy in the bone marrow. We choose back here because that's easy to get to. And if we miss, we go a little bit one side, there's not much we would hurt by missing to one side or the other. So that's why we pick the pelvic bone to go after. And most of the time, you can tell that the myeloma cells are there because the protein that they make, you can measure and you can see. And finally, most people do have those holes in the bones. There is a condition that's kind of a precursor to multiple myeloma that some people in the audience may have. It's called IEMMSG, or it's in some ways a terrible name, but it's monoclonal gammopathy of unknown significance. So what that means is you can see there's a growth of this, you can see there's a buildup of the protein in the blood, the protein that the plasma cells are making. So if there's a buildup of one single antibody protein in the blood, there must be a buildup of one cell that's kind of made a bunch of copies of itself. So people with this are at risk of developing multiple myeloma, but may just stay that way for years. So a gentleman I just did a bone marrow biopsy on a few days ago, I've been seeing him for 15, 20 years. And the reason it's called IEMMSG, it used to be called benign monoclonal gammopathy, well, because in his case it wasn't so benign. It itself caused nerve damage. It made the protein, the antibody protein, was making his feet numb. And now he's becoming anemic, so the question is anemia because these cells are growing, or is there some other reason why he's anemic? So that's why I did the bone marrow biopsy on him. And then, not to scare you, but there's another condition that I think it's recognized. It's called amyloidosis, and that's where the protein, the light chain protein that these cancer cells make, can build up into the tissues. And some people I take care of, that's the only way they know they have a problem, is there's been this buildup of the light chain protein, and it builds up in their kidney, or builds up in their heart, or builds up in their intestines, and makes those things not work. The treatment is you get rid of those cells. So it's you treat it just like you treat multiple myeloma, but it's some people can unfortunately have both. They have multiple myeloma and have this particular condition, this amyloidosis. Yes.
Would that be classified as a solid tumor?
It's not a solid tumor, because solid tumors are just non-blood tumors. I think any non-blood tumor is a solid tumor. So, because the only things that kind of float around are blood. So any solid tumors are things that the organ is solid. I mean, we think of blood as not solid, pour it out. So bone marrow, which is where myeloma cells are, you can, I suck it out, it's in a syringe, you squirt it into a dish. Lung cancer, it's a lump. So that's the solid tumor. Breast cancer, it's a lump. So this just is the protein kind of infiltrates, like kind of gets inside all the healthy normal tissues and makes it not work. It just makes it more important to get the disease in remission. The staging system for multiple myeloma is listed here, the one we currently use. I'm going to tell you right now, I don't think the staging system is that important. It only is important when you were diagnosed. Doesn't make it there. This is not breast cancer, this is not lung cancer, this is not colon cancer, this is a liquid cancer, not the solid tumor. So staging is not so important for liquid cancers. We don't have when little kids get leukemia, when adults get leukemia, there is no stage. And myeloma is more like leukemia than, if you kind of think of how it works, than it is like lung cancer. Lung cancer starts in the lungs, spreads to the lymph nodes, then spreads to the other parts of the body. Well, blood goes everywhere. So it's usually kind of all over the place. It may be, certain places more than others, but myeloma cells float around. So it's not like it goes from one spot, then goes to the heart, then goes to the brain. It doesn't do that. It just kind of starts everywhere. So the staging system is helpful for studies, and everybody always, wants to know what stage am I at, but frankly, it's, as treatments have gotten better, it really isn't as important for this particular disease, and it only makes a difference at the diagnosis, not later on. Probably what's more important is, why is that cell cancerous? So in order for a cell, cells are little tiny things you can't see. If one was sitting there on the table, I wouldn't be able to see it. You need a microscope for it. What tells it what to do? The instructions are the genes, the chromosomes inside the cell. That's what tells the cell what to do. It tells it to make antibody proteins, or it says divide, or it says just sit there and wait. So what happens with multiple myeloma is some of those genes are missing. So some people have an absence, that cancer cells have this piece of chromosome is gone. And you figure, well, why would that be bad? Why would that make the cell behave badly? Well, because within that piece of the chromosomes, it says don't divide signal. So if you get rid of the don't divide signal, don't grow signal, well, now the cell grows when it wasn't supposed to. Other things like this, a lot of times in multiple myeloma, the problems are the mistakes happen around chromosome 14. Well, chromosome 14 is where the antibody is made. That's the gene that it makes the antibody. And plasma cells, the healthy cells, their function, the reason we have a normal plasma cells is to make antibodies. So in a normal plasma cell, this chromosome 14 is where all the action is. That's the part that's making the cell go. So what happens is if that chromosome, instead of staying where it is, gets moved over and placed in a different part, chromosome 4 or chromosome 16, now this chromosome 4 has a bunch of traffic going on. Or this chromosome 16 has a bunch of things happening there, when it was supposed to that part of the gene was just supposed to be sitting there. And so that makes it, for people that the cancer cells have this. You're not born with this abnormality. Just the cancer cell. If the cancer cell has this, then it's, at least at the moment, it's harder to get rid of those cells. Usually the treatment works, but it just makes it more likely for the cancer to grow back. It just makes the cells divide more frequently. Yes?
As I understood it, the composition of the blood, plasma is the liquid part of the blood.
Yeah.
Is there a difference between that and a plasma cell, or are they one and the same?
They should never have called the two names the same, because that is very confusing.
Okay.
Plasma is like, just like you said, the soup that carries the blood cells, and a plasma cell is, they should have called it antibody cell.
I see.
And it would have made it a lot better. But a lot of times when these things are discovered, they don't know the whole, somebody gives it a name without really knowing what it does. And so that's what happened there. This thing, amyloid, I showed you, that's because they thought it was starch, starch and pasta. But amyloid's a protein, which pasta doesn't, that's different. So, yeah, I agree. That is very confusing. We should rename it, antibody cell. They call it multiple because when you would see it, multiple myeloma just means multiple white blood cell tumors. So myelocyte is like a white blood cell, but the terms are bad. I agree, and it was because somebody came up with the term 100 years ago, and they didn't know what was 100 years ago. We didn't know so much. But in order, as I put first point there, in order for there to be a cancer cell, something's wrong with the genes inside it. There's nothing wrong with the genes inside your cheek, your eyes, your hair, your skin, only in the cancer cell. And that's what made it a cancer cell. So probably, and in the near future, and what would make a lot more sense, is to take, a handful of those cancer cells, if people have multiple myeloma, and figure out exactly what's wrong. Because then if you know that, you might be able to say, well, this drug was going to work because this cell that cancer has this mistake. And somebody over there with their myeloma doesn't have that mistake. It has, extra chromosomes. And so that's, and not these switching of translocations of chromosomes. So that's probably the better way of deciding how best to treat people. But right now, we're not quite at a point in time where we can take out a cell and determine exactly what's wrong with it. But it's getting close. It's amazingly getting closer and closer because, 20 years ago it was thought you couldn't sequence the whole human genome. Now they do it, in a week. So how do you treat the disease? Well, obviously you have to slow down the growth of the disease, get people in remission, reduce their symptoms, and somehow figure out a way of keeping it from coming back. I think here's the thing. Not every treatment is going to be the best. There is no best treatment at the moment. Maybe one day there will be, because you give these three drugs and it just universally wipes everything out. But for multiple myeloma, and I'm sure when talking with others, some people, Kyprolis works great. Other people didn't do anything. Some people, thalidomide was a wonder drug. Sometimes for other people, not so much. Some people, steroids work, but boy, they're hard to take. So you got to try to use something else. So you do have to come up with different treatments for different people, and usually you need a combination of treatments. It's, you're trying to get rid of these termites, or ants, which seem to keep coming back. If you use one type of poison against them, they might be resistant to it. So if you attack it from three different ways, it's more likely you can get rid of it. So how do we treat it? Well, drugs, give supportive care, which is the things that kind of allow you to tolerate the treatments. Transplants can be done. Radiation is a way of killing the myeloma because it damages cells that are dividing. So radiation, it kills dividing cells. So the more they're dividing, the better it kills them. So myeloma cells, since they're dividing more than your skin, it's just kind of sitting there, then that's why the myeloma can die with the radiation. The problem is, you can't radiate the whole body very easily without hurting a lot of other healthy stuff. So I'm going to go through some of the drugs that are used, and then and kind of why they're being used, and then we'll just kind of take it as it goes here. Thalidomide was used a long time ago. Unfortunately, babies that were born from mothers who took thalidomide were born with short arms and legs. And the thought was that that's because this drug blocked the growth of blood vessels. So obviously, if you're a little baby inside a mom and you need your arm to grow, you need blood vessels to grow with it, because this part of my arm's got to have blood vessels too. So if the drug blocked that from happening, the arm can't grow. And so that's why babies came out with short arms and short legs. When Dr. Barlowgy in Arkansas looked in the bone marrow patients with multiple myeloma, he noticed there was a lot of extra blood vessels in there compared to people without multiple myeloma. So the thought was, well, maybe the blood vessels are important, and maybe we should try thalidomide, which can block those blood vessels, and that might make myeloma go away. So that's why he tried it. But sometimes you just get lucky, and he, a smart guy, and maybe got lucky too. But the thalidomide just happens to kill myeloma cells directly. If you take a plate of myeloma cells, put thalidomide in there, it can kill them. And it also blocks some of the hormones that myeloma cells need, the fertilizer for the myeloma cells. And it also alters the immune system, boosts the immune system to attack the myeloma. So it wasn't just, it did this, blocks the blood vessels, but did all these other things too. And frankly, we're not sure what's more important. We actually think this is the least important of them all. So that's why I tried it. And that's how science works. If you kind of, all of a sudden you see something, and sometimes you just get lucky, and it opens up a whole new avenue of how to treat the disease. And thalidomide works, and I have patients still taking thalidomide. I have people who have been on it for 10 years and counting, and it became kind of the standard treatment for multiple myeloma 10, 15 years ago. The other drug frankly, going back to this, the other drugs, lenalidomide, which is Revlimid, pomalidomide, which is Pomalyst, they do the same thing, just maybe more potent in this area or that area compared to thalidomide. But that they work in kind of the same mechanism. Bortezomib prevents this growth hormone called NF-kappa B from getting inside the cell and turning on all these signals to have the cell divide and make other hormones. So this drug actually blocks this thing called a proteasome, and the proteasome breaks down this process and allows this thing to get inside the cell. So it's complicated, but the bottom line is the bortezomib blocks this proteasome, and by blocking it, it keeps this blue and green